What if I told you we were wasting over an hour per patient waiting for a lab value that changed imaging decisions 0.3% of the time? Picture this. A young, healthy woman has been waiting for over an hour in the hallway. She needs the result of her kidney function test before she can have a CT with contrast to rule out a pulmonary embolism. How many times can you recall an abnormal kidney function test changing your imaging plan on any of your patients? I can count on one hand over a 10-year career. But how often do you see patients like the one in hallway 4 here, waiting for their labs before going to imaging? Multiple times per shift, every shift. I'm Dr. Megan Winters, emergency attending, operations leader, and evidence-based medicine committee chair. I'm here to introduce a high-impact operational shift to remove unnecessary barriers to diagnostic imaging based on the latest evidence. Let's look at a roadmap of how we'll structure our discussion today. We're going to start with the problem and how we do things now. Then we're going to look at the evidence for change, a vision for a revised protocol, and our comprehensive implementation plan. Now that we know where we're headed, let's start with some background on the problem. Our current policy is rooted in outdated dogmas that overstate the risk of kidney injury related to contrast administration. As things stand now, almost every patient waits an hour for the results of kidney function testing before they're able to obtain a contrast CT. In emergency medicine, time is paramount. By treating every patient as high risk, we're inadvertently introducing delays that are more dangerous than the contrast itself. What appears to be caution might actually be leading to unmeasured harms in the form of diagnostic error and delay. Look at this photo. There's a lot of patients that can't wait for that CT. Now that we understand the problem, let's move on to the updated guidelines that prove universal screening is no longer necessary. Research indicates that modern contrast agents carry a much lower risk of kidney injury than previously thought. The 2025 American College of Radiology guidelines emphasize the need for updated protocols, shifting away from universal screening toward targeted assessments through history taking. A recent study looked at whether patients could be risk stratified with a simple question: do you have a history of kidney disease? If the answer was no, they were deemed low risk. The authors found that 16,000 patients in this study, only 0.3% of the low risk were later found to be at risk for kidney injury from IV contrast based on their lab values. So if we can identify 99.7% of patients accurately without a lab value and without waiting, why are we delaying care for everyone? Given that the risk of contrast is significantly lower than historically believed, let's look at how targeted screening can also decrease wait times. This is from another recent study that looked at the patient-centered impact of targeted screening. On the y-axis here, we have our order to scan time. And on the x-axis, you can see the universal screening on the left and then targeted screening on the right. As you can see, targeted screening drops order to imaging time from 24 to 13 minutes, nearly half the time. Implementation of this protocol can boost departmental efficiency without compromising safety. We have the evidence for safety and for speed, so let's look at what a targeted screening protocol might look like for our institution. This flowchart illustrates a novel targeted testing workflow that is reflective of updated guidelines. This protocol follows in the footsteps of other academic leaders like Yale and the University of Wisconsin that have already moved to eliminate universal screening. Next, I want to go into detail about our comprehensive implementation strategy. To operationalize a change like this that is so deeply ingrained for so many of our staff, we need a broad-reaching campaign to support collective commitment to this new workflow. We're going to introduce a systematic educational overhaul, integrate our new policy into our CT order set, emphasize emergency overrides when needed, and perform quality analysis to ensure that our protocol is having its intended effect. To overcome the outdated dogma of universal screening, we need to address deeply rooted cultural, systemic, and educational obstacles. Our goal is that staff understand and believe in the evidence behind the change to targeted screening, rather than just abiding by another workflow change. Our goal is for a long-lasting impact of this new protocol and to bring evidence-based medicine to the way that we do things here. In summary, replacing a one-size-fits-all policy with targeted clinical screening will yield faster throughput and better quality of care without compromising on patient safety. Let's ensure the next patient in hallway 4 gets their diagnosis in half the time. I recommend bringing our updated protocol to the next faculty meeting to field any additional feedback. We are on track to go live next quarter. Let's return to a model where evidence-based medicine and clinical urgency guide our care. Thank you for your time. I'm eager to answer any questions you might have, and if you need more time to consider my proposal, my contact information is at the bottom for any other feedback. Thank you again.